Okay, today we're going to take a look at Chapter 8, and it's our fifth lecture on joints. This is part A of a two-part presentation. We also refer to joints as articulations. So an articulation is a site where two or more bones meet. And the functions of joints are to give the skeleton mobility as well as holding the skeleton together. So we need to take a look at how we simultaneously have mobility and we're stabilizing the skeleton or holding it together. So within that, we get into these functional classifications of joints. So based on the amount of movement allowed by the joint, so we're really, the key thing here, we're interested in movement. Within that, then, we have three functional classifications. A synarthrosis, the syn saying that it's width, is going to tell us that we have this joint that is, so the arthro is the joint. We have a joint that is with another bone, so it's so with it that it's an immovable joint. Amphiarthrosis, when we see amphi, we think amphibious, or maybe it has a foot in two different realms, which in this case it does. It's slightly movable. And one of our favorite joints is a diarthrosis, which is freely movable. So we see these within shoulders and knees, things like that. So continuing in along this line, we're going to take a look at the material that's binding bones together. So here we're interested in this structural classification, and previously we were taking a look at a functional classification. So in our structural classification then, we're taking a look at the material binding the bones together and whether or not a joint cavity is present. So a joint cavity is an important structural classification that we need to look at. Within this then, the three structural classifications are fibrous, cartilaginous, and synovial. So we could have a joint that's classified. We're going to have two classifications for every joint. One that's based on movement, and then the other that's going to be based on the material binding the bones together. So those are two of the ways that we're going to take a look at how these joints are named. So we jump in with fibrous joints, and we see that fibrous joints are bones joined by dense fibrous connective tissue, and there's no joint cavity. Most are synarthrotic or immovable. We have that with the arthrosis, or with the joint, so that's immovable. And we have three types of these fibrous joints. So one of the things that you're going to see with joints is how do you keep these straight? And the classification is just going to have to tie in, maybe taking a look at a table or something that could pull these together nicely, but thinking that generally if we run into a fibrous joint, we're for the most part synarthrotic or immovable. The three types of these joints would be sutures that we've seen in the skull. So, for instance, if we're looking at the top of the skull, we're in a superior view, and we have the sagittal suture that runs back, and then we have our coronal or our frontal suture that's in the anterior or frontal bone portion. Another type would be a Syndesmoses and Gomphoses. So we'll take a look at both of those specifically, or all three of these. So specifically looking at the sutures, these are rigid interlocking joints containing short connective tissue fibers. So there had been some questions previously about what keeps these sutures together, how do they form, and when we start out, if we take a look, at say a superior view of a baby's skull, in that area where we have what ends up forming as our coronal suture and our sagittal suture, before those form up, we may have like a fontanelle type of shape. So these fontanelles then continue to ossify, and as they come together, as they get closer together, they have these connective tissue fibers that are tying everything together. This allows for growth during youth, and in middle age, sutures ossify and are called Synovial. So here we change over to the osto. We're still with, so what we're saying is we have bone with bone. Whereas previously, when we were taking a look at this, we would have a synarthrosis. So still saying that arthro, or say for arthropods, and so we consider it an immovable joint that later comes together so much that it's referred to as a synostosis. So that's what we look at sutures being in their final formation as we've aged, as a synostosis. So we've seen a few of these sutures. Taking a look at those, if we, we've seen temporal, frontal, lambdoidal, and just that idea that we have that formation of dense fibrous connective tissue, but then later in life, as that more further ossifies, we have a synostosis. Syndesmosis, we're still in the fibrous joint category. The bones are connected by ligaments, and if we remember that ligaments are bone to bone, so when we think about this, we have bone to bone for ligaments, whereas when we take a look at muscle integration into bone, then we have a tendon. Movement is going to vary from immovable to slightly movable, and examples of this would be synarthrotic distal tibiofibular joint. So the joint between the tibia and the fibula would be considered to be synarthrotic, so not movable in this type of structure. And then also taking a look at a diarthrotic interosseous connection between the radius and the ulna. So this one is somewhat movable, we know, because the radius has to roll over the top of the ulna when we have pronation. So if we're going to pronate, we have to have a certain amount of movement there. So the key being that a fibrous joint that's a syndesmosis that brings together bones with ligaments, and within that we have this range that can be immovable to slightly movable, and we take a look at a couple of examples of tibiofibular and the radius and ulna at the interosseous connection. So just taking a look at that syndesmosis, this connection here, we're at the distal end of the fibula and the tibia, and we have this ligament tying them together, which creates that syndesmosis. A Gomphoses then is peg and socket, joints of the teeth and alveolar sockets. When we see alveola, we'll see alveoli in the lungs, and then we've seen alveoli within the pockets that hold the teeth. And there's a fibrous connection that is the periodontal ligament. So again, bone to bone with this ligament, and what it's actually doing is holding each of our teeth into the bone of either, if we're interested in the mandible or the maxilla, then these ligaments are important to holding our teeth directly into the bone. So a Gomphoses. Another category, as we step out of the fibrous joints to cartilaginous joints, the bones are going to be united by cartilage. So here we're going to have no joint cavity, and we have two types that we look at, Synchondroses and a Symphyses. So here we see that syn, the width again, but we shift over to our chondro, which is the cartilage, and then we see Symphyses or Symphysis that has a special position as well. So Synchondroses, so again with the cartilage, a bar or plate of hyaline cartilage is going to unite the bones, and all of these are synarthrotic, so very immovable for the most part. When we take a look at these examples, being that epiphyseal or our growth plate, temporary hyaline cartilage joint, as those epiphyses separate from the diaphysis, then if we were to take a look at these joints between the first rib and the sternum, this is an immovable joint, and those would all be Synchondroses. And these are examples looking at hyaline cartilage, bringing them together. A symphysis then is typically going to be an arrangement where we have hyaline cartilage covering the articulating surfaces and is fused to an intervening pad of fibrocartilage, strong and flexible amphiarthrosis. So this flexible component comes into play when we take a look at the amphi part of this arthrosis. So a symphysis, bones united by fibrocartilage, and some examples that we have would be these types of joints where we're looking at our intervertebral discs. And a big one that we take a look at is just within the area of the pubic symphysis, this region in here, to where there's hyaline cartilage against the bone, but then there's fibrocartilage sandwiched in between. And so that's kind of a typical thing. We can see that same thing when we're looking over here at this hyaline cartilage perimeter that then has a fibrocartilaginous disc in the center. And we have annular rings on those discs, and it's those annular rings that usually have a problem with then failing and causing a bulging type of situation, where then the spinal nerves that pass out of this intervertebral foramen are going to get pressure from this bulging portion of disc and cause pain as that nerve that passes out gets pressure put on it. Synovial joints are, all of these are diarthrotic, and so what we're looking at here are all of our limb joints, and most of the joints of the body are going to be synovial joints. So one of the bigger types of joints that we study are the synovial joints. Some distinguishing features of them: the articular cartilage is hyaline cartilage. The joint has a synovial cavity, which is also looked at as a small potential space. So there's this small amount of space in these synovial cavities that allows for certain special functions of the joint. Distinguishing features: we have an articular joint or capsule, and this should be a 1. Sorry about that. The articular joint capsule has an outer fibrous capsule of dense, irregular connective tissue, and the inner synovial membrane has loose connective tissue. So we have to take a look at this idea that there's this capsule that has the different layers to it. So we have this outer dense, irregular connective tissue, and then we have this inner area that's going to be our loose connective tissue. So just different areas there that perform differently. So here's kind of a simplified model of a synovial joint. And so we can see that we have this articular or hyaline cartilage that's on the epiphyses of these bones. And then we have this fibrous capsule out here surrounding it. And then we see in between sort of this overlap as we go from hyaline, and then we have the hyaline, and it ends with this transition into what we're interested in here as this synovial membrane. So the synovial membrane is the cells of that are what are responsible for producing and releasing synovial fluid into the joint capsule. Then we have this transition that we see in a lot of times whenever we have something going from bone to bone. We have the integration of this fibrous capsule into the periosteum. It actually transitions into that outer covering on the bone. So this one should be number 3. And there are 3 possible types of reinforcing ligaments. There are capsular or intrinsic, which are a part of the fibrous capsule. There are extracapsular that are outside of the capsule, and intracapsular that are deep to the capsule, covered by synovial membrane. So intrinsic or capsular, extracapsular, and intracapsular. So just dealing with, if we're capsular, we're in the fibrous capsule, so we're on that outer portion of this model. Then if we're extracapsular, we're outside of the capsule. And if we're intracapsular, we're deep to the capsule, covered by synovial membrane. So some of these then, when we look at this model, it's good to come back and reference this model for your location in terms of, are we within the capsule, or are we extra to that, or are we intra to that? So a lot of it has to do with a reference to this capsule. Some distinguishing features of synovial joints. These joints have a rich nerve and blood vessel supply, and we need that because these joints move so much that we need to be able to detect pain, monitor joint position and stretch. And then within this, we have capillary beds that are going to produce the filtrate for synovial fluid. An interesting addition within synovial joints that we see a lot are bursa. And so bursa are these little flattened fibrous sacs that are lined with synovial membranes. They contain synovial fluid and commonly act as ball bearings where ligaments, skin, tendons, muscles, or bones rub together. So where we see these then are in these relationships where, say we have the humerus positioned here, it has this hyaline cartilage on the outside of it, and then we see this bursa in this area here that then has a ligament that's spanning over the top of it. So we have an issue here where this ligament, if it didn't have this bursa fit in between it and the humerus, you could imagine that with a lot of movement that we're going to potentially burn out the hyaline portion of the humerus, or we might burn out some of this ligament. So bursa are these anti-friction little inclusions that have synovial fluid, and they just are these kind of squishy sacs that help reduce friction and help us not burn out more of our bones, muscles, ligaments, all of these different items. So some of the friction reducing structures, we have a tendon sheath that is essentially an elongated bursa that wraps completely around a tendon. So this then, a lot of times in this arrangement here, if we think about carpal tunnel, a lot of times what happens with repetitive movement of a tendon is that this bursa can actually be worn down, and we can start to have inflammation and pain that occurs from that. So bursa are not just these little pads, they're also these structures that can entirely enfold or, wrap around a tendon or something like that. Stabilizing factors of synovial joints, we have shapes of the articular surfaces. So just thinking that, if we have a shape that that is going to, that we're interested in, then we usually see, like say we have a condyle and then we have a fossa that receives it. So those shapes of the articular surface help to stabilize the joint. We have ligaments, and so the quantity of those ligaments and where they're located are going to play into the stabilization. our muscle tone, which is going to keep tendons that run across the joint taut. And this is extremely important in reinforcing shoulder and knee joints and arches of the foot. Because when you think about it, in order for us to have this amazing flexibility of the shoulder and the knee, we have to simultaneously allow it to be almost completely flexible and then pretty immediately turn around and be very taut and held in place. And so you can kind of see with this juxtaposition of fluid motion and tautness that we could run into some problems with that. So just things to think about with the stabilizing factors of synovial joints. Movement then within these joints, we see that muscles attach across a joint. So this attachment across a joint plays into which muscles affect movement of the bone. So when we look at muscle, we have an origin that is an attachment to the immovable bone, and an insertion that's attached to the movable bone. The way that we name most muscles is we start with their origin, and then we go ahead, and the second part of their name is their insertion. So if we look, for instance, at clidomastoid, so that what this would say then is that we have our origin at the sternum and the clavicle, and then we insert at the mastoid. So this muscle then is going to take the head and go ahead and, let's say this is our little mastoid, and that muscle goes down and it ties into the clavicle and the manubrium, and then the flexion of this muscle pulling our head down is going to, just rotate the head down, or give us a side-to-side motion. Muscle contraction causes the insertion to move toward the origin, and movements occur along transverse frontal or sagittal planes. So we're interested in this. This will come into play a lot more when we get into our muscle unit. Our range of motion, we have to take a look at a couple things that synovial joints have different ranges. Non-axial, slipping movements only. Uniaxial, movement in one plane. Biaxial, movement in two planes. Or multiaxial, movement in or around all three planes. So there's a table in the book, 8.2, that has a good summary that has all of these joint names, articulating bones, structural classification, functional classification, and movements allowed. So we want to get comfortable with that because it's going to come into play when we get into muscles.